Hi, I am Dr. Selvaraj, Professor of Surgery, Malacca Manipal Medical College, Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to listen these videos over and over again. In this episode, I am going to talk on one of the fascinating and challenging problems, namely surgery in bleeding diathesis. Surgeons are doing surgeries because of normal blood clotting and wound healing. Suppose if the patient is not having the normal blood clotting, then this will be a big problem to the surgeons, and it is a challenging and a fascinating problem. This is how to approach these patients. That is what I am going to discuss in this episode. So I am going to talk on the following subheadings, namely the introduction, physiology of hemostasis, pre-op evaluation, cases managed by me, the common bleeding disorders encountered by the surgeons, surgery in hemophiliacs, and finally the clinical vignettes. So what is the surgery in bleeding diathesis is a challenging and fascinating problem. The pre-existing hemostatic defects can be detected with proper history and physicals and screening lab tests. However, occasionally the first sign of the defect would be excessive intra-op bleeding that could have been a nightmare to any surgeon. So even a minor tooth extraction can cause death if it is an unexpected bleeding disorder. This girl, actually, they did everything, the thorough history and physicals and the screening lab tests, but they were not able to pick up any bleeding disorder. Say they did a tooth extraction, but unfortunately after the procedure this girl bleed to death. So this can happen even in minor procedure. So coming to the physiology of hemostasis, it consists of four components: the vessel wall response, the platelet activities, coagulation cascade, and fibrinolytic system. So the vessel wall response, the intact endothelium of the blood vessel that maintain the fluidity of the blood. Once this endothelium is disrupted, that will initiate the hemostasis process. So immediately after this endothelial disruption, the platelet will go there and adhere with the denuded endothelium by one branding factor. And first thing is adhesion of these platelets to the endothelium, and the next thing is the aggregation to an unstable mass by both fibrinogen and thromboxane A2. So here you are seeing a cut section of the blood vessel. This is the endothelium, where the endothelium is denuded in this area. So the platelet will come and get adhered to this denuded endothelial surface by this blue is the von Reckling factor. So this will adhere to this one through this receptor GP1B receptor, and this is the adhesion, and then aggregation of other the other platelets can take because of fibrinogen and thromboxane A2. This is taking place in the receptor called GP2B complex receptor. So this is the 13 coagulation factors. I am not going into detail of all these things. You can pause the video and you can read everything. So this is the coagulation pathway. It consists of intrinsic, extrinsic pathway and a common pathway. So in intrinsic pathway, the factors involved are 12, 11, 9. So the activated 9 will go and activate the factor 10. This is the intrinsic pathway, whereas the extrinsic pathway, there is a tissue factor that will activate the factor 7 to activated factor 7. So that will activate factor 10 to activated factor 10. This activated factor 10 will convert the prothrombin into thrombin. So this thrombin will act on the fibrinogen and convert it into fibrin monomer. Then this monomer will become a fibrin polymer, which will be acted by factor 10, and then only a stable clot will form. So this intrinsic pathway will be assessed by the PTT, partial thromboplastin time, whereas the extrinsic pathway will be assessed by PT. And then the common pathway you can assess by thrombin time. So this is the once the clot is formed, finally it has to be dissolved also. So the fibrinolytic system will be activated by the transformation of plasminogen into plasmin by tissue plasminogen activator, or TPA will convert the plasminogen into plasmin, and this plasmin will act on the fibrin, and this will dissolve the clot, and there will be a formation of fibrin degradation products and D-dimer. So thorough personal medical history, family history and drug injection history you have to obtain. Then you have to do a thorough physical exam. So you have to examine the skin for evidence of any petechiae. If it is petechiae, most probably it is thrombocytopenia. Or you have to look for ecchymosis or hematoma. So both are platelet dysfunction or thrombocytopathy. You have to examine the joints also for evidence of hemarthrosis. This will happen in case of very severe coagulation defect. You have to look for organomegaly also. Hepatomegaly denotes coagulopathy of cirrhosis. If there is splenomegaly, you have to suspect thrombocytopenia. So broadly, these bleeding disorders you can divide into platelet disorders and coagulation factor disorders. So in platelet disorders, the site of bleeding will be either in the skin or mucous membrane, whereas in coagulation factor disorders, usually the bleeding will be in the deep soft tissues like joints and muscles. Petechiae is more common in platelet disorder, whereas it is not common in coagulation factor disorders. Ecchymosis is very small and it is superficial, whereas the ecchymosis is very large and very deep in case of coagulation factor defects. Hemarthrosis and muscle bleeding is extremely rare in platelet disorders, where it is very common in coagulation factor disorders. Bleeding after cuts and scratches are common in platelet disorders, whereas it is very uncommon in case of coagulation factor disorders. Bleeding after surgery or trauma is usually immediate and it is mild in case of platelet disorder, whereas the bleeding will be delayed only after 1 to 2 days, and if it is also very severe. So you must also do some basic screening lab tests. You must do the platelet count. The normal is 150 to 250,000 per deciliter. If the count is low, that means it is thrombocytopenia. Bleeding time, the normal is 2 to 8 minutes. This will be increased bleeding time in case of thrombocytopenia or in thrombocytopathy, that is functional disorder of the platelet. Prothrombin time, the normal is 12 to 14 seconds. We will be assessing the extrinsic system that comprise the factor 7. Partial thromboplastin time, normal is 30 to 40 seconds. Here we will be assessing the intrinsic system and the factors 8, 9, 11 and 12. Thrombin time, the normal is 12 to 20 seconds. This will be low in case of hypofibrinogenemia, and in case of heparin, this will be increased. Actually, it's not low, this will be increased, thrombin time. The fibrin degradation product assay is normal is 10 microgram per ml. This will be abnormal in case of DIC and in fibrinolysis. So this is again laboratory approach. You have to do the blood film, you have to look for the platelets morphology. The morphology is abnormal. You have to do the platelet function test. Probably the patient is having thrombocytopathy or functional abnormality of the platelet. And then you have to look for the number of the platelets. If the count is decreased, then it is thrombocytopenia. Suppose if the platelet morphology and the count are normal, then it is a case of coagulation factor defects. Here you have to do both PT and PTT. If PT is abnormal and PTT is normal, so this is a disorder of extrinsic pathway and we are assessing the factor 7 deficiency. If the PT is normal and PTT is abnormal, okay, we are assessing the disorders of the intrinsic pathway that comprises the factors 8, 9, 11 and 12. If both PT and PTT both are abnormal, we are assessing the disorders of the common pathway. So deficiency of factors 2, factors 5 and factors 10. So this happens also in vitamin K deficiency and those patients who are taking oral anticoagulants. So if, and another thing, the PT is abnormal, PTT is abnormal, even thrombin time is also abnormal, then you have to do the platelet count. If the platelet count is also decreased, then it is a case of DIC. This can also happen in end-stage liver disease and in massive blood transfusion. Suppose if the platelet count is normal, then this may be a case of hypo or dysfibrinogenemia and the patient is also under some thrombolytic. So coming to the various cases which we have managed, the case number 1, it is a 2-year-old firstborn male child was brought with obstructed right inguinal hernia. There was history of epistaxis and EC bruisability. So ear boring ceremony resulted in prolonged bleeding. This is an emergency, so extensive workup was not done. Emergency herniatomy was done. So the basic screening tests reveal hemoglobin 11 grams. Only the bleeding time is prolonged, 15 minutes. Prothrombin time, PTT, all are normal. Blood group is B positive. So only BT was, that is bleeding time was prolonged. So the provisional diagnosis is functional platelet problem, that is the thrombocytopathy. So emergency herniatomy was done with 200 ml of fresh whole blood. The patient was readmitted after 10 days for prolonged bleeding from a small cut to the upper lip. He was managed by multiple whole blood transfusion. However, we sent blood for a complete hematological workup that revealed the bleeding time is prolonged 15 minutes. There was no clot retraction, there was no clot lysis, and the platelet function test revealed in vivo platelet adhesion is only 10.8%. ADP aggregation was absent. Aggregometer studies reveal ADP no aggregation, collagen also no aggregation. However, the thrombin time is normal. So this patient is having a normal platelet count and morphology, normal clotting test. Only problem is the prolonged bleeding time. He is also having absent platelet aggregation with both ADP and collagen, absent clot retraction. So this is a case of a congenital inherited platelet problem known as Glanzmann's thrombasthenia. Case number 2, he is an 11-year-old boy with no known history of any bleeding diathesis. He underwent emergency appendectomy. He started oozing from the operated side in immediate post-op period. In subsequent interrogation, parents came out with the history of ingestion of aspirin tablet by the boy. Labs reveal bleeding time is prolonged. Both PT and PTT are normal. Platelet count is also normal. So since this is a functional disorder of platelet, that is thrombocytopathy, the boy was treated with platelet concentrates. Case number 3 is a 4-year-old boy was brought with pain abdomen and fever for 1 day. On examination, abdomen was diffusely tender and rigid. So abdominal X-ray erect revealed free gas in the diaphragm. But the boy is a known hemophilic. Since it's an emergency, we did laparotomy and ileal perforation closure was done with anti-hemophilic factor or the factor 8 concentrate. On second post-op day, the boy was oozing from the surgical site. So factor 8 assay was done in hematology lab and dose of anti-hemophilic factor or the factor 8 was adjusted. Case number 4 is a 5-year-old boy with history of fall over cycle bar presented with retention of urine. On examination, there was drop of blood at urethral meatus, perineal hematoma, and extravasation of urine were present. So emergency SPC was done after confirming rupture urethra with retrograde ureterogram. The next day, the boy started bleeding from SPC site. On subsequent interrogation, parents told the boy is a known hemophilia. He was also managed with anti-hemophilic factor or the factor 8. So what are the different hematological disorders commonly encountered by the surgeons? These are thrombocytopenia, thrombocytopathy, hemophilia A, Hemophilia-B, that is Christmas disease, von Willebrand disease, disseminated intravascular coagulation, liver disease that involves factor 7 and factor 10 deficiency. So coming to the thrombocytopenia, it is where you will be having low platelet count. It may be acquired or it may be inherited. Usually there will be superficial bleeding in form of purpura or ecchymosis. Labs will reveal the BT is prolonged, that is the bleeding time is prolonged. Platelet count is also decreased, whereas the PT and PTT both are normal. Treatment is you have to give platelet concentrates. So thrombocytopathy, this is functional platelet abnormality. This is acquired due to drugs like aspirin and uremia. This may be also inherited if it is defective platelet adhesion, that is known as the Bernard-Soulier syndrome, which I have discussed in the case number 1. If it is defective platelet aggregation, that is a case of Glanzmann's thrombocythemia. Sorry, I didn't describe the Bernard-Soulier. It is the Glanzmann's thrombocythemia which I described in case number 1. Labs will show the bleeding time is prolonged, whereas the platelet count, PT and PTT all are normal. There may be superficial hemorrhage in form of ecchymosis and epistaxis. The treatment is you have to give platelet concentrate infusion. So hemophilia A, this is factor 8 procoagulant deficiency. This is a sex-linked recessive inheritance. There will be deep tissue bleed and there may be hemarthrosis also. Lab will show PTT will be prolonged, platelet count, PT and bleeding time all are normal. You have to do individual factor assay also to find out whether it is hemophilia A or hemophilia B or any other clotting factor deficiency. Treatment consists of anti-hemophilic factor or the factor 8 concentrate. You have 1 unit per kg raises the level by 2%. So for a 5 kg baby, you have to give 250 units for 100% raise. If the factor 8 is not available, you can also use FFP and cryoprecipitate. Hemophilia B is due to factor 9 deficiency. This is also known as Christmas disease. This is also sex-linked recessive inheritance. There will be deep tissue bleed and hemarthrosis. Labs will reveal PTT will be prolonged, whereas the bleeding time, platelet count and PT will be all are normal. You have to do individual factor assay to find out whether the factor 9 is deficient. Treatment is you have to give either factor 9 concentrate or you can give FFP. Von Willebrand disease. This is factor 8 von Willebrand factor deficiency. This is an autosomal dominant inheritance. This patient may present with epistaxis, EC bruising or prolonged bleeding from dental extraction. Labs will reveal both the bleeding time and the PTT. Both are prolonged, whereas the platelet count and the prothrombin time are normal. So you have to do individual factor assay. The factor, this is factor 13 deficiency, you can make out. Treatment is either you can give the cryoprecipitate or you can give FFP or you can give DDAVP. So disseminated intravascular coagulation is a thrombohemorrhagic disorder. It may be, it is an acquired bleeding disorder. maybe because of abruptio placenta, septic abortion, toxemia, gram-negative sepsis, massive tissue injury, snake bite, etc. Activation of coagulation cascade will produce microthrombi throughout the microcirculation. There will be consumption of coagulation factors, platelets, and fibrin. There will be also activation of the fibrinolytic system. Patient may present with mucosal bleeding, oozing from the wound sites, and ecchymosis. Labs will show all the parameters are prolonged, namely the bleeding time, the platelet count, PT, PTT, and thrombin time. Everything is prolonged apart from FDP and D-dimer, both will be increased. So the treatment is, you have to treat the underlying cause mainly. You can give FFP and you can also give platelet concentrate. Advanced liver disease is also an acquired bleeding disorder where there will be factor 7 and 10 factors will be deficient. Patient will present with epistaxis, maybe female patient with menorrhagia and hemarthrosis. Labs will show both bleeding time and platelet count are normal. If it is factor 10 deficiency, the patient will be having both PT and PTT, both will be elevated because this is the common pathway. Suppose if it is only factor 10 deficiency, only PT will be prolonged, whereas the PTT will be normal. You have to do specific factor assay to know whether it is factor 10 deficiency or factor 7 deficiency. Treatment, you can give FFP and you can also give vitamin K. So bleeding diathesis can be broadly divided into platelet disorders and clotting disorders. So the platelet disorders, it may be functional defect, thrombocytopathy, or it may be thrombocytopenia. You have to, in case of thrombocytopenia, you have to do bone marrow biopsy also. So you have to treat the primary disease, and most of these cases will be treated by platelet concentrate. Clotting disorders, again, it may be congenital or acquired. The congenital bleeding clotting disorders are Hemophilia-A and B or von Willebrand disease. So these can be treated by fresh frozen plasma, or if you know it is Hemophilia-A, you can give the individual specific factor you can give, or you can give cryoprecipitate or the consent factor concentrate you can give. So the acquired clotting disorders are after giving, suppose if the patient is getting heparin. So this is, if you are giving more heparin, okay, that will produce bleeding. So you have to give protamine. This is the antidote for heparin overdose. You have to give protamine to counteract this bleeding. So if vitamin K deficiency, this occurs in end stage liver disease, you can give FFP. So if it is this also occur in liver disease, also advanced liver disease, you can give FFP and cryoprecipitate also. If after multiple blood transfusion also bleeding can occur. This can also, here you can give FFP, cryoprecipitate and platelet transfusion also. If it is consumption coagulopathy or DIC, you can give FFP, cryoprecipitate, platelet concentrate, and the role of heparin is controversial. If it is hyperfibrinolysis, you can give FFP, cryoprecipitate, platelet concentrate and EACA. So surgery in hemophilia, you have to give factor 8. The dose should be calculated to bring the patient's plasma level to 100% 1 hour prior to surgery. 50 units per kg, or you can give 50 units per kg every 12 hours. We have to assay daily prior to the dosing. For minor surgery, maintain the plasma level more than 60% for the first 4 days. Maintain the plasma level more than 20% for the next 4 days. For major surgery, you maintain the plasma level more than 60% for the first 4 days, whereas maintain the plasma level for more than 40% for the next 4 days. If it is for orthopedic surgery, you maintain the plasma level more than 80% for the first 4 days and maintain the plasma level for more than 40% for the next 4 days. So now I am going to show you some case vignettes. So the first case is a 40 years old man came to the hospital with complaints of bleeding PR. So colonoscopy revealed a single polyp in the descending colon. Colonoscopic snare polypectomy was done. Post-operatively, he started profuse bleeding. So labs reveal only bleeding time is prolonged. All other parameters are normal. So what is your diagnosis and treatment? Since bleeding time is prolonged, this is a platelet problem. But since the platelet count is normal, this is not thrombocytopenia. This is a case of thrombocytopathy. So diagnosis is thrombocytopathy due to aspirin injection. On subsequent interrogation, the patient revealed that he was taking aspirin regularly. So treatment is you have to give platelet concentrates. So case vignette 2, a 3-month-old baby with congenital biliary atresia was brought with purpuric skin lesion and oozing from the gums. Labs reveal both PT and PTT or both are prolonged. Bleeding time and platelet count are normal. So what is your diagnosis and what is the treatment? Since both PT and PTT are prolonged, this involves the common pathway. So diagnosis, this is a biliary atresia baby. So it is an advanced liver disease. Treatment, you have to give FFP and or you can give individual factors, both factor 7 and factor 10. So case vignette 3, this is a 3 days old baby was brought with history of hematemesis and melena. On examination, the baby is a well baby, no problem. So labs reveal all parameters are normal. So what is the diagnosis? So this is a baby is normal baby, so there is no pathology actually. The baby swallowed the maternal blood during the labor and subsequently vomiting the same. So no need for any treatment. So case vignette 4, 6 years old man, a case of ESRD on chronic hemodialysis. You were called to see him for profuse oozing from the puncture site at AV fistula. Labs reveal PT and TT, that is thrombin time, both are prolonged, whereas the bleeding time, platelet count and PT are normal. What is your diagnosis? The diagnosis is heparin overdosage. Since the patient is on hemodialysis, he was receiving heparin. Because of the overdosage, he started oozing from the puncture site. So you have to, the antidote for heparin overdose is protamine. 1 milligram will counter 1 unit of heparin. You can calculate and you can give the dosage protamine accordingly. Case vignette 5. 12 years old girl on chronic hemodialysis for end-stage renal disease. She developed uremia because of temporary interruption of dialysis. She developed brisk epistaxis. Her labs reveal BUN, that is blood urea nitrogen is 164 milligrams and bleeding time is more than 20 minutes. So what is your diagnosis and treatment? Patient is in uremia. So uremia can cause platelet functional problem. So this is thrombocytopathy due to uremia. You can treat it with platelet concentrates. So case vignette 6. 50 years old lady with severe burns injury became febrile and toxic. On examination, she had epistaxis. She also presented with hematemesis and melena. Wound swab of the burns injury revealed gram-negative sepsis. Labs reveal all parameters are prolonged apart from FTP and D-dimer also prolonged. So what is your diagnosis and treatment? The diagnosis is DIC and you have to treat it with FFP and platelet concentrate. So thank you very much for watching my video. If you think that these videos are very helpful, kindly share with your friends. Kindly subscribe to get notified regarding my latest uploads. Thank you once again for watching this video. Bye bye until we are going to meet in yet another episode.